Good morning, and first of all, I should thank RCC, CASO, Dr. Chandramohan and his team for this arranging this wonderful meeting and inviting me to stand in front of you. And I think over the years, endoscopist has stepped into many of the areas of surgeons, and this is not an exception. We know that my topic is given is malignant rectal polyps. There are certain definitions of malignant rectal polyp. It's actually a tumor which is confined to the submucosa, not beyond that. And the management actually changes. But now in practice, for endoscopists, we define malignant polyps slightly differently. Whichever is possible to be resected, in whatever type of malignancy, we take it as a malignant polyp. But we know that when it goes beyond submucosa, it is actually adenocarcinoma. You have to label it as a cancer. Though it is others also a cancer, but it's early cancer. But because of the screening programs and because of the wide use of colonoscopy, this is being picked up more frequently. But the resection extent and the type of removal all changes rapidly. So in my talk, I just would like to touch upon like this on assessment of a polyp, which I will be very brief because there is another session on that. Then what is meant by advanced colonic polyp, and what are the endoscopy resection techniques, what is meant by extended endoscopy resection, and then assessment and take-home message. See, whatever we do, we actually aim for only these areas of resection. A tumor which is confined to the mucosa or just beyond the muscularis mucosa or in the submucosa. When you assess a polyp, there are different varieties of tests which we can do. One is that you look at the morphology, size, location, etc. And I think the most important things are the surface pattern. And we have a very good technique of looking at that, that is image enhancing endoscopy. Where we have got chromoendoscopy, where you spray dyes, or we can have digital chromoendoscopy where the endoscope, so the computer itself defined that, that is, example is NBI. Then we have got higher magnification system, magnifying endoscopy, or we have got something called endocytoscopy. Now artificial intelligence has come in a big way. It can actually detect polyp. The ADR, adenoma detection rate, has increased, but also it characterizes the polyps. Then we have some evidence that by endoscopy we can say the depth of invasion. This is one which we commonly follow, that is a Japanese NBA experiment, JNet, where we divide the polyps in different types, which we will discuss in detail during the next session. But type 2B and type 3 are quite important for endoscopy resection or surgery, whatever it is. Pit pattern is another important thing, and I think looking at for it, I think you have to spend time for that, and it is quite relevant. And this is actually the macroscopic or the overt signs by which say this is an advanced cancer. When you inject for resection, non-lifting, or extensive chicken skin sign, or a depressed area in the polyp, and then there is a convergence in the polyp. So these are the type of, these are the evidence of submucous invasion. One is the stiffness of the lesion. When you touch, or when you do a perirectal examination, it is a rigid lesion which is actually attached and is non-mobile. Then this actually says that probably it's or a surface ulceration without any prior manipulation. Because when you spray water, if the surface erodes, that is bleeding, I think it is very likely that this could be a malignant one. Or when you look at the pattern, Kuto's pit pattern, if it is 5N, then it's quite important. Then as I told you, type 3 JNet. And in the esophagus, we know that if the lesion extends up to M3, this is it. You know that then itself you can have lymph node metastasis. What about in stomach or Barrett's esophagus? It is less than 1%. But in colon, up to that lesion is 0. So that gives an advantage for endoscopy resection. So what about it goes beyond into the mucosa? Up to 1,000 micron in the submucosa of colon, it is endoscopically resectable. But in the esophagus, it is only 200 microns, and the stomach, it is 500 microns. If suppose you want to have a curative resection, en bloc resection is the best, and that will give the pathologist the correct histological assessment. So what is meant by an advanced polyp? This is actually a polyp which has some evidence of malignancy, and that is an advanced polyp. For example, when there is a feature of Willis features or high-grade dysplasia or features of sessile serrated adenoma, or this patient has a traditional serrated adenoma of any size, these are considered advanced polyp. Sorry. So let us come to the most important area, that is the endoscopic resection techniques. There are different types of polyp, you know that. There is a pedungulated polyp, subpedungulated polyp, then there is a sessile polyp. And sessile polyps, they are big, we call it as lateral spreading tumor. And lateral spreading tumor has the different types, which we will discuss during the next session. And when it is a pedungulated polyp, we generally go for a conventional snare polypectomy. And advanced endoscopic techniques is for lesions which requires resection either in the form of a mucosal resection, either by EMR or EST when there is a suspicion of tumor, and en-bloc resection versus piecemeal resection. I will come to it later. This is an example of a person. I think Chandramohan referred this case, I think. This is a colonic polyp, a pedungulated polyp in a patient with ulcerative colitis. This is the white light. This is the narrowband image. So you can see the difference here. Two areas, JNet type 2A, 2B in the top and type 3 in the below. And we decided to go for endocytoscopy. You can see this. This is a magnifying 520 times. See, we put some colors, methylene blue and crystal violet, and you can see the microscopic pictures there. You can see the cell nucleus, the dark color cell nucleus, and the computer will tell you it is a neoplastic lesion. This is artificial indolence. So we decided to, this is a pedungulated polyp, long pedicule was there, we decided to go for endoscopic resection. We put 2 endo loops to prevent bleeding, so we cut in between, and it was resected. And this you can see, we have seen these areas malignancy and these areas high-grade dysplasia. You can see this histopathology, the similar picture. So this was a tubulovillous adenoma with adenocarcinoma, inverse up to SM1, that is less than 1000 micromillimeter, and stalk is free, margin is more than 1 centimeter, and LVA, or lymphatic invasion, is absent. So similarly, Dr. Andrea has shown that, Haggett's classification is quite important, For all resected specimens, we ask our pathologists to look for that. And it is different for sessile versus pedungulated polyp. Pedungulated polyp, even if it is going to a submucosa, if it is the head of the polyp, that is considered to be a resectable one. What about piecemeal resection? Generally, we do not recommend it because the pathologists find it very difficult to really give an answer. But in certain situations, when there is difficult to do that, then we do it. For example, right colonic lesion, very high chance of perforation, thin colon, recurrent lesions, lot of scarring is there. In those cases, preferably we do it when it is a non-malignant one. If this is a right colonic lesion, we have done an underwater EMR, and that is piecemeal also. It was a non-malignant one, but you can see that it is completely resected, and the further margins are also cauterized. This turned out to be a lesion with a high-grade dysplasia. There was no evidence of malignancy. Overt malignancy is this one. Underwater EMR is a good technique. What happens is that the mucosa involutes into the lumen so that cutting becomes easy. We don't inject saline underneath. It is actually underwater EMR. So what about en-bloc resection? We have EMR, full thickness resection, for lesions less than 2 centimeter. For lesions more than 3 centimeter, preferably we do EST. This is an EMR. You can see a lesion, which is a sessile one. You can see a chicken skin appearance there. We inject saline, you can see that. It is elevated. We use indigo carmine along with that because that stains the submucosa. It stains the submucosa, so you can see the muscle very well. So when we cut, you go through the submucosa. Here it is less than 2 centimeter. We used a snare, and it is a complete resection there. See, since it is quite deep, we decided to close it also. sides are cauterized with margins because it's cauterized to prevent further growth on that. When you go for submucosal dissection, it is slightly different. It's a larger lesion. You can see you mark the sides of the lesion and inject, and then start cutting, incising on all around. And you see that you can see the muscles very well there. We are going very close to the muscle, but not to prevent make any damage on that. Then finally it is taken out. So this is a complete resection. And the specimen is taken out in total and spread it so well to help the pathologist how to look for that. And sometimes we mark the proximal margin so that the pathologist will find it very easy to tell us where is the lesion. You look at the base of the lesion very well to see, look for perforation, bleeding vessels, etc. So like this, we have to spread it out and then we present to the pathologist. So it is easy for them. Suppose there is a lesion is extensive, it actually goes in depth. Then you can even if it is small, then you can actually use a full thickness resection of the lesion. The lesion is sucked in, there is a cap there, it is pulled with the forceps, and then use a device to cut it. It's a very easy technique. This is one of that. You mark around that, then you suck into the cap. Sometimes to go into the pylorus, it may be difficult, so we dilate it. Or someone is the rectum, if it's going in, is not very well, we just dilate it. Because the device is quite thick. I don't know how to fasten it. Anyway, skip it. But this is another case where this actually you can see that this is a lesion which is 2A at sometimes, and some places it is 2B. How can I make it fast? Anyway, it's okay. So whatever it is, usually I can do something here to make it fast, but I'm not seeing it. Anyway, it is resected, and this actually turned out. You can see, just to show you that the tumor is extending up to here. And this is a submucosa. Nothing is there. Oh, I'm sorry. Anyway, I think the most important thing is that we should sit down with the pathologist. And all our major cases like this, we sit down with MDT, and then I go to the pathology department, sit down with them, and then I discuss. And many times, when the beginning period, I'm talking about 2011, 12, and at that time, pathology was not very well versed with ESD. So I used to go to and sit down with them and how to mount and all. Now they have become an expert on that. I'm so sorry about this. Where did we lose? This one? Can you go back once more? One slide more? Okay, I will show. It is not moving. I think I'll skip that. Time is over? Yeah. So I think this is very important. This view is very important. Tumor and then the distance. We always discuss the pathologist. We want to know how much micrometers it is going down. That will help us to. So now I think there are certain situations where you need to do an extended resection. Convention is fine. A lesion which is in the mucosa or in the proximal or in the early submucosa SM1 is fine. We have discussed that. There are certain situations where you think this patient requires an extended resection, or in certain situations we do something called a staging ESD. So this is actually a male, 80 years, not a very good candidate. And you can see this lesion is on 2B, actually Janet 2B to 3, and it is extending, probably touching up to the muscle. So we did an extender resection here. This is a rectal lesion. The patient would otherwise end up with a stoma. So we are just cutting. We are going very close to the muscle. We can see we are just making some. This is actually we are cutting through the pocket-like opening. Some days even we may make an injury to the muscle. Here we are not worried because we are in the rectum. We can actually suture it easily. We can do endoscopy closure. And this is being dissected out. So this is actually, this is a little deeper one, and you can see this. This is the histopathology. You can see that these are actually not just tumor buddings, but the tumor actually extends up to muscles, So it's a deeper one. And this is another case. This is an 85-year-old male, multiple comorbidities, and distal rectal growth, and endoscopic ultrasound. We generally, distal rectal growth, and we generally do US because we think it's a little more safer for us, and it is a T2 growth. We know that the muscle is involved. So what to do? MDT discussion, naturally it's straight away go for surgery, otherwise radiation chemotherapy, but in this patient now we thought if we can resect that and then we can actually go for further treatment. The patient is actually generally not willing for any therapy, so we are just told that we can do this. You can see that. Tumor is resected. You can see the fat there, the perirectal fat, mesorectum is seen there. But it's okay for the patient. We actually resected completely. And this resection actually showed a complete resection. But there is LVI. There are no, actually this does not have any lymph nodes in this patient, but the tumor resection is complete. It's R0, but except it is LVI, we cannot call it sir. This is another patient, a very interesting case. And this man has this growth. He is actually 83-year-old, multiple comorbidities, CKD, one dialysis, and prostatic cancer, so many things. In fact, this has come from Trivandrum, I think. So what to do? We had multiple discussions with the patient. Patient is not willing for surgery because of all these reasons. So we decided to do something differently. So this is a growth. We decided to go for endoscopy resection. We did an EUS. So you can see the growth goes up to the muscle. We did an ESD on this patient. But I know that the ESD will not be sufficient because we may make an opening in there because it is not in the rectum, it is actually beyond the rectum, and it is in the rectus-sigmoid junction, likely to make a hole in there, and not a good candidate for surgery as well. But I'm sure now surgeons have got excellent skills and you got laparoscopy, you can do very well. We discussed everything. And in this case, we resected and we found there is a muscle involvement. So we did a full thickness resection there using an FTRT. It's a combination technique. And I will show you the histopathology report. This is actually, ESD showed involvement and the base is involved. But full thickness resection specimen, no tumor cells, no emboli seen. So for this patient, it is an R0 resection. He has no lymph nodes, and he is severely comorbid, and he is very elderly person. And then, in certain situations, we have to take a decision like this. This is a very early case of cancer. See, this is actually a person, young person, who had 2 operations for cancer of, colorectal cancer, and this is a lesion in the right colon. You can see that. I can easily remove endoscopically, but I did not do because this is, on look-wise, it is an invasive cancer. Because why I am telling is, see, the surface, it is eroded, surface pattern is lost, it is Janet type 3, and I am sure this patient will have invasion. So what is the final result on this? Surgery was done. It is a moderately different adenocarcinoma, SM1, LVI is present. So if I had done an endoscopic resection, again you would have gone for surgery. So I think the sensible judgment is very, very important, and this is aided by narrowband imaging also. And this is a new technique, which I told you. This is actually endocytoscopy, which can tell you that this is a tumor which cannot be operated, cannot be endoscopy resected, this should go for, because this will tell us whether there is invasive cancer or not. If your clinical judgment is not adequate, computers can help you, artificial intelligence can. This is shown that is invasive cancer. So I have come to my last part. It is, what are the post-ESD complications? I think perforation is the most dreaded one, but fortunately it's much less in our center. Because why? Because very, very careful, and it is done very slowly, and I tell my people, you just do it, but don't make any complications as such. Bleeding will be there, but even if it's there, perforation, but you can suture it many times. This is it. You can see there is a perforation. We actually close it. You can see the peritoneum there. Nothing happened for this patient. Pathology important, I think, is very important. You have to see the histopathology, especially differentiation, margins, and I think the under surface is most important. Surface margins, side margins we can handle. We can go and dissect it again. But if it is involved, the below or the under margin, then the depth or vertical invasion, it becomes problem. And when you do a gross resection, if microscopically it is okay, but that is not sufficient, the pathologist has to tell that it is complete. This is, I am telling you about horizontal margin positive. It is considered to be a local risk resection. And then in these patients, we actually go ahead with further resection if required. Surgical intervention, if it is invasive, definitely more than 1,000, we have to go for surgical management if it is possible, otherwise. And undifferentiated carcinoma, margins, positive or non-evaluable vertical margins, I think you should go for surgery. And this is when there is doubt, bring back all your colleagues, MDT, and then whether the need for chemotherapy or surveillance or this one. How do you follow up this patient? I have come to my last slide. Follow up this patient. We generally ask them to come back after 3 months for an endoscopic assessment, and then colonoscopy 1, 3, and 5 years. This is my take-home messages. A thorough endoscopic assessment is very important, and this is to find out whether there is any risk of submucosal invasion is present or not. And imaging enhancing endoscopy is actually a very integral part of follow-up evaluation. And you choose the right resection technique. Don't jump into what is available there. If it's not available, refer to somewhere. There's no harm. But choose what is the best for the patient. And piecemeal is as far as possible avoided in a malignant lesion. In a benign lesion, it's fine. And ESD is useful for embolic resection. If it's anything more than 2 or 3 centimeter ESD. And in high-risk surgical candidates, I think you have to choose your mind, and you see that the patient requires what. And in that situations, you can consider extended resections. In borderline cases, I still prefer to do a staging ESD to decide. And we explain the patient that we are doing an ESD on a staging basis, and this is, if we find there is any advanced stage, then you have to go for go for surgical management or chemoradiotherapy. Thank you so much for your kind attention. I am so sorry for taking more time.
Thank you, sir. That was a very elaborate and informative talk on endoscopic management of malignant colonic polyps. So my question is, you already made it clear. So many times what we see is sometimes patient comes to us with an already resected colonic polyps diagnosis of malignancy. So would you recommend all this endoscopic resection in centers with NBA only? And also regarding the role of cross-sectional imaging prior to this colonoscopy?
I did not answer report because of time constraint. Because 12 minutes I found it very difficult to talk on this aspect. See, imaging is mandatory. In all these patients, we do imaging. Imaging means a CT scan. Our protocol is, I don't know, in most centers I think is same. In rectal, we use a rectal MRI. We actually do a imaging protocol for patient of rectal lesion. So a rectum will be MRI, and they do a CT abdomen and a chest if it is an advanced one. Otherwise, we just do MRI, rectum, and a CT abdomen. And then in those patients where I would like to do a resection, or my colleagues would like to do, I recommend them to do a rectal EUS, actually a bulky lesion, then to find out that. And I think a combination of this is very important. And if you ask me, should somebody do a resection with Olympus 170 scope, and I won't recommend, because that time was gone. Now we should know what is the character of the polyp, what is the surface pattern of the polyp, what is the extent of the polyp into the mucosa, submucosa, and to the muscle. I think, if I have seen many patients refer back to me after doing polypectomy saying the base is involved. And you do a EOS or you do an imaging and find out it's actually a stage 2 or it's actually T2 lesion. Already it's infiltrated the muscle. So if we would have evaluated earlier, we could have actually avoided that resection. Instead, the patient would have gone for surgery. I actually do all this advanced procedure only in patients where surgery is not possible or surgery relatives are not all willing, patients above the age of 80 years and all. Young patients will immediately tell them, no question. You have seen that patient. Very early lesion, I can easily remove endoscopically. I don't know. Surgery is the best for you. There is no doubt regarding that. Thank you.
Sir, actually it's the right attitude, looking into the tumor biology and of course with experience. We are sending a lot of patients to you. We are seeing nearly 300, 400 colorectal cancer patients every year in RCC. And every year, every month, we have one patient who is having early lesion, which we think patient does not need a radical surgery. So those patients we are selecting and sent to people like you. It's very I think the one important issue we are facing is lack of experts in India. So being the secretary of...
No, I think we are having a lot of people who are being trained. And when I started in Kerala, I think, I went for the first training outside Japan, that is in Hong Kong, in 2004 or 5. And when I came back, actually I did not have any equipment to do that. I was using needle knife to do that. But, it's not good. And when it really came to India in a big way, actually we started doing that. There are so many people are being trained. And in Kerala, there are so many. In my center, it is 4 or 5 people are doing.
Yeah, I agree. But I think most of the beginners are starting and slowly things are changing. And I strongly feel that radical surgeries has to end for a significant number of patients where we have to have an opinion based on MDT, where such early patients, and every year I'm relieving a patient otherwise decided for a radical surgery. I'm saying no, we'll do just a polypectomy even for younger patients. I think, and that kind of expert discussion, deliberations has to be there, and surgeon should be there, the endoscopist should be there, and the radiologist should be there, and that's only way to go forward.
I think CASO and not CASO, ISO and IST should work together too.
I think Dr. Subramanian Rao sir, I think we should do some jugalbandi.
I think it's very important because
like you do. I think one concern when they do a higher lesion is perforation. So why can't a laparoscopic surgeon verify there is no perforation and repair it? So most of the procedures now it's high time we should escalate to some sort of jugalbandi between endoscopic surgeon as well as a laparoscopic surgeon.
No, it's not a cost. Actually, the patient will benefit.
Dr. Aniruddha want to ask something.
So from a clinician, when you find a significant polyp, should you do a biopsy and send it to you, or you prefer no biopsy? Because I think you should not do a biopsy when you're planning ESG.
Yeah, and I agree. It's actually a very good question. See, it all depends upon. Suppose when I do a colonoscopy and I see polyps which are endoscopically resectable, not ESD, I'm telling ESD because we have to explain to them the risk and all. All other polypectomies I just do during the colonoscopy. Because now we have got a technique called cold snaring. All small polyps does not require a hot snaring. It's actually just cut it and go. Then we have got a sump-like thing attached to a suction. So all the polyps will come there. Small polyps. So finally sent across to histopathology. And that is, but when there is a major resection, then we actually delay it because we need to assess it and you need time to look for it and we need to discuss and we need to image the patient, we need to discuss in MDT and take a final. In those patients, I take biopsy. But I agree that the concept of a very flat lesion, if you take a biopsy, endoscopy resection like submucosal dissection may be slightly difficult because it can produce scarring. But it is not a problem if you take only one biopsy, then it's not a problem. And I'm telling you now, even scarring is not a big issue. We actually do use a dry cut and just cut slowly. And even if there is a hole happens, it's not a major issue now because we can close it, we can hold endoscopy suture techniques now. So these are not major concerns. Only my worry is that if you make a hole, whether this will actually produce a dissemination of the disease into the peritoneum. That is my concern.
Continuing with the previous comment about the experts, As laparoscopic surgeon, we all go for training after completing this super specialty program for a long period in robotic as well as laparoscopy, and I feel that there is a lot of things are aligning in the interventions you do and we do. Are you recommending, after passing out medical gastro degree, are you recommending any training program?
Yeah.
And what's the learning curve for starting these procedures?
See, I tell you, in gastroenterology is a wide field. It's a very vast field. There are people who can go for IBD, people can go for manometry, people can for luminal gastroenterology, people can go for research, people can turn into endoscopist. Endoscopy, that is actually just like cardiologist, no, invasive cardiologist and non-invasive cardiologist. Endoscopy also we have got invasive endoscopy is non-invasive endoscopy. Just do endoscopy and go. But in that also you have got ERCP, you have got EUS, there are so many things, And now we actually recommend even surgeons to become endoscopist, and they are actually good endoscopic for third space. This is what I am telling about third space, for example, POEM, ESD, full thickness. I think surgeons can do a better job in that, and I am sure that the endoscopy degrees or endoscopy training will change in the future, where surgeons and physicians both can join. And it is
It's a very good suggestion, sir.
that is what I think, because they are so good in that. When I did my first poem, my heart was beating like that. It's more than the patient's heart beating. Tuck, tuck, tuck. I'm seeing all the media stenum, And later, after doing some 100 cases only, actually you settle down. Yes, this is it. But otherwise, doing ESD also, when I did the first ESD, it's a challenge for me. But now it is not, because even our younger colleagues are also doing. But I always think that, you should be having, now the youngsters have no patience. After him, they just jump to do a poem, just want to do an ESD. But learning process is a slow process. It is not a sudden jumping process. Okay. I think
one more question.
Yeah, just one last comment. I think a lot of what is discussed is important, but the key thing is to identify what is a significant polyp. And both surgeons and endoscopists need to speak the same language to say, when we see on endoscopy a polyp, is this significant? Is this likely to be malignant? We've got a lot of endoscopic features, we've got size criteria, and at that point to take a step back, not try and do something immediately, and then maybe do an imaging, discuss with a radiologist or discuss an MDT and come back and do a one-time treatment. Doing something, seeing a polyp and just excising it or trying to do something at that point is what actually leads us to this common scenario of polyp excised, malignant, we don't know what the margin is. So identifying a significant polyp, both for surgeons and for endoscopists, and then taking a step back and saying, okay, we will come back on another day and tackle this is, I think, one of the very key features that we have to.
I think that is good. I think, I got a group of surgeons which they tell that even a patient is referred to them, and they call me and say that medical gastro, sir, this is not a case for surgical resection. This can be amenable by endotherapy. I think that is very important. When sometimes a patient is referred to me and I tell this is not for me, this has to go to a surgeon. So that type of attitude is very important. Thank you so much.
I think Divakar, on the other way around, an endoscopist has EUS and he detects it. And what makes you inferior to a surgeon? He can also decide things, because that's a way of thought process, at least in UK, where endoscopists diagnose things. They have an EUS, the skill set is there. They diagnose and cures polyps then and there itself. All polyps need not be imaged by MRI or CT scan. Thank you, sir.
Thank you.